Hi, everybody. Good afternoon. Thanks very much for coming to this webinar today, where we're going to look at women with PD and the effect of hormones on our symptoms and what we can do with that information. I'm delighted to have you all here, and I'm going to start today's webinar with a presentation of a survey that the PD Avengers did of women with Parkinson's. And it was shared out across many different Facebook groups where Parkinson's women attend, and on Twitter. And I'm delighted to say that we got close to 200 people responding. And we did actually have one of the surveys translated into Spanish as well. So I'm just going to share that with you now to kick off. Okay, so women with Parkinson's, the hormonal impact. I'm delighted as well that thanks you to the Cure Parkinson Trust, which is a PD Avenger partner, for hosting the webinar today. So just in terms of an introduction, I'm going to do a backdrop to the survey. I'm going to take you through the results, and we're going to move on then to a panel discussion around the survey and women in Parkinson's. So just in terms of research shows that the symptoms differ between men and women in terms of motor symptoms. So you'll see here on the left, women tend to suffer from more tremor, pain, dysphagia, more frequent falls, gastrointestinal dysfunction, dysphagia. Those are the more predominant motor symptoms of women. In terms of the non-motor symptoms, which actually research shows affects the quality of life of people with Parkinson's more than motor symptoms do. And I just want to do a shout out to Johnny Atkinson, who is a PD Avenger, who actually put this pictorial image together. And it just shows that for women, anxiety, depression, pain, motor or fine motor skills, fatigue, loss of smell tend to affect women more. And the other thing was on Twitter, there was a big discussion with regard to women's symptoms being affected by menstruation. And that actually, you know, for women, 1 week out of every month is affected by their menstrual cycle. So this image was again put together by a male PD Avenger, a man with Parkinson's, and he put this together to represent the issues for women, which is, you know, 1 in 4, we deserve more. So in terms of women need more support around their hormones affecting their Parkinson's symptoms. So this led me to actually join with Maria Teresa Ferretti from the Women's Brain Project on International Women's Day, where it was about choosing to challenge bias and in research, gender bias against women. And I suppose one of the things is that a lot of the research shows that women are different, and yet we're not getting probably focus on the treatment for women with regard to their Parkinson's symptoms. So I'm going to bring you through here in terms of the survey results that we did. So it showed here that we asked people, did their symptoms of PD worsen around their menstrual period? And it was a resounding 74% said yes, their symptoms did get worse. In terms of the symptoms got worse, it was bradykinesia, rigidity, and dystonia, interesting enough, were the ones motor symptoms got worse. So something to do with that stiffness of movement being affected by estrogen dropping around the menstrual cycle. In terms of non-motor symptoms, there's a raft of symptoms that are affected by in Parkinson's, and for women, it showed that around menstruation, the ones that were most affected, fatigue was number 1, followed by anxiety, depression, insomnia, apathy, excessive sweating. They were the key things that were affected. Now, interesting enough, in the Spanish survey, depression and anxiety weren't the highest. Apathy was, insomnia was, pain was, and fatigue. So interesting there in terms, I'm wondering, anything to do with northern latitude or southern latitude and vitamin D, or I'm not too sure what's going on there. In terms of symptoms being the timing of symptoms, generally speaking, the week before was seen as being the worst effect on symptoms, and this is probably to do with the drop in estrogen, estrogen showing to be neuroprotective. But there were some women who, you know, during the weeks of bleeding and even after it stopped, that found that their symptoms were still worse. Then we looked at perimenopause, and there was over 60% of women said that their symptoms did fluctuate randomly during perimenopause, and that also it was difficult to control their symptoms. Similarly, 64% difficult to control their symptoms. And I'm just showing here in terms of postmenopause, we asked, were your symptoms better after you'd gone through the menopause? And it was sort of, 60% said about the same, but interestingly enough, in the women who did the Spanish survey, it was actually worse. Not too sure why, but just, I suppose, shows that maybe we need to look at different areas around the world. And then we asked about who had hormone replacement therapy. So majority, there was about 20% who did have hormone replacement therapy, but in the survey that just looked at the Spanish women, actually was much less. It was only about 3 or 4%. Again, not too sure why. And then the effect of HRT on Parkinson's symptoms, did you notice whether it was better, about the same, or worse? So there was a kind of about 42% who said that they felt the symptoms of Parkinson's were better. In terms of the timing of HRT, we asked women when they took it. So the majority took it during perimenopause. And there is some research to show that taking HRT during perimenopause may improve symptoms, possibly slow progression, but there's kind of mixed results in the research. And then one of the most interesting areas was we asked questions about neurologists' engagement around hormones and the effect on Parkinson's when they talk to women. So we asked, did the neurologists discuss the impact of hormones on PD symptoms? Did they ask about, or did they adjust medication around their cycles? Did they suggest HRT? Or did they discuss the effects of perimenopause or menopause on their symptoms? And I think you can pretty much see a resounding no. So this obviously is a big concern in terms of, discussion around hormones. It's having a big effect, as you can see from the survey results, and yet the discussion is not being had in the clinics. So I just want to introduce our panel today to discuss these survey results. We have with us Elena Moro, who is a professor of neurology at the Faculty of Medicine at Grenoble Alpes University. She's the co-chair of the EAN Task Force on Gender and Diversity Issues in Neurology. We have Dr. Maria Teresa Ferretti, who is a co-founder and chief scientific officer of the Women's Brain Project based in Switzerland. We have Louise Ebenezer, who is a Parkinson's disease clinical nurse specialist at the ABM University Health Board in Bridgend, UK. We have Dr. Kathy Molahan, who's a PD advocate, a WPC ambassador, PD Avenger and Director International Relations of UVIDO, Germany. And we have myself and Helen Matthews, who is behind the scenes here from Cure Parkinson's Trust, and who's also PD Avenger along with myself. And just to mention, really in terms of being inspired by the Women's Brain Project and by all of the women who are out there working in Parkinson's and looking at women in Parkinson's, myself and two other PD Avengers and WPC members set up the Women's Parkinson's Project because we want to raise the voices of the issues of women living with Parkinson's to improve the care and ultimately maybe find a solution to slow the progression, halt it, or even cure Parkinson's. Wouldn't that be someday? So I'm going to pass over now. I'm going to stop sharing my slides. So let's say today's format is very much going to be a kind of discussion. People can ask questions through the Q&A function. So please put them in there and we will ask your questions. So first off, to kick off the discussion, ladies, if I were to ask you what you felt was a standout result from the survey, what would you pick? So I'm going to start with Maria. Sorry, if you wouldn't mind unmuting yourself then, Maria.
Got it. Hi, everyone. Good afternoon. And thank you, Rochelle, for the invitation and for organizing this webinar and also for organizing the poll. When we had a look at the results, what struck me was that there were two things. One is that the population that you surveyed actually confirmed something that we have seen in the literature. So it is known that you have these fluctuations of symptoms related to hormones, in the menstrual cycle, the menopause. So that was, reassuring to me to see that this is something that is actually seen in the population. But the one thing that really caught my attention was the attitude and the engagement of the neurologist. And this is something I hope we will have a chance to discuss today. So in the face of this obvious fact that patients are experiencing, it looks like there is a not sufficient discussion or engagement of the neurologist, possibly awareness or knowledge of how to manage these problems. So this, I think it's really a key point related to patient management, and I hope we will have a chance to discuss this with the others.
Yeah, absolutely. So actually it brings me on to Elena. Obviously, you've set up this task force on gender and diversity issues in neurology. What for you is a standout?
So thank you, Richelle, and thank you everybody for being here today. I think there is, as Maria said, there is a lesson for the neurologists, right? So we learn when we are medical students that we have to ask about this, when the women start with the periods, the menopause, but then it looks for neurologists, maybe the gynecologist is much easier. We forget, right? And we have to say that, there is a prevalence of men in getting Parkinson's disease in an older age. So we almost forget, right, that they can be young women still not fertile, that they can get Parkinson's disease. So we forget to ask these points. So I think is quite important, right, to raise awareness that these are things that we have to remember to ask our patients, above all if they're women, as we ask about other stuff in our clinics. And as we will discuss later, how to deal with these issues, right?
Thank you, Elena. So Louise, I'll come on to you. What stood out for you?
Thank you for inviting me. I agree with the two ladies. It's the lack of understanding or the lack of asking about the question, but also do the patients actually think about it and contribute? I think it contributes to part of the disease process each month when they have their periods. But the biggest standout for me was the motor issues. I know non-motor issues are huge and we deal with them on a daily basis and they're overwhelming and all-consuming for people. But it was the bradykinesia and the rigidity was more standout for me, rather than, I know tremor would be a big problem and I know low mood and fatigue, but it was the motor symptoms that were more problematic during that time. And if you think that would be quite considerable time that your motor control is much worse during a year, it's quite a significant part of your life, isn't it, in a year?
So I think that's really interesting. I suppose two things on what Elena said about the young. I know in Ireland, for example, that we have a number of juvenile onset Parkinson's, and I'm just kind of thinking, like, it's huge for them around their menstrual cycles and these symptoms, and then, as you say, it really stood out to me with regard to those stiff symptoms, the bradykinesia, the rigidity, the dystonia. So I was kind of wondering, and maybe that's something we can discuss, is it something to do with estrogen that has an effect on those kind of rigid sort of symptoms? So I might go to Anne-Lynne next in terms of what stood out.
Sorry, can you hear me? I'm not hearing you. Oh, now I hear you again. Well, thank you. You forgot to introduce me, but I am a gynecologist in the Netherlands, Rotterdam. Now I moved to the Radboud University Medical Center, and thank you for this opportunity to be in this meeting. First of all, I myself have Parkinson's, and this was just a confirmation of my own belief that there's really cyclic changes, cyclic pattern in your symptoms and Parkinson's. It's something I noticed from the beginning, maybe because it's my profession as well, but I was convinced that it had influence from the beginning onwards, and this survey just confirms my belief. And so thank you for that. And Also, I think the most striking was the neurologist engagement on this topic. I think it's really not enough knowledge under neurologists, and therefore it's under discussed. I think from both sides, from the patient as well as the professional, it's not brought on to the table and in the outpatient clinic. And I think there should be much more awareness, but as long as we don't have the knowledge, it's a difficult topic to discuss because we don't know how to manage this. So we need to find out really much more. But thank you for this first answers. It's really nice.
Thanks, Lillian. And Leanne, I'm really sorry that I left you out by mistake. That
no
wasn't
problem.
deliberate. I think it was hidden behind the screen. Anyway, I'm so sorry. So
No
absolutely delighted to have you here, because having a gynecologist who has Parkinson's is just huge to bring to the table. So delighted to have you here. So Kathy, as someone, you know, living with Parkinson's as well, maybe you could share what you think is the standout part of the service.
Sure, thanks Rochelle, and thanks a million for getting us all together today. It's very exciting to have this meeting of minds. I think there's two main things, but the huge one for me is, I think what most of us have said already, the fact that the neurologists just are not asking these questions. It's just incredible to me. I was diagnosed in my late 30s, so very clearly, you know, in the middle of my menstrual life, so to speak, and I'm now in my late 40s, just had DVS last year, and never once, not once, has any neurologist ever said anything to me. And you know, shame on me, I should have maybe drawn attention to this myself. You know, it's only something I've become aware of in recent months almost, which is shocking in and of itself. And you know, to be facetious about it, when I go to the beauticians and get my legs waxed, she says to me, don't come when you're just about to have your period, it's much more painful. And if my beautician can say that to me, you know, why in God's name is my neurologist not aware of this? So yeah, I think that's the huge thing for me.
Brilliant, thanks, Kathy. I think it sounds like neurologist, the gap between what women are experiencing and what's been discussed. And I think it's to be honest, it's not only to do with Parkinson's. I think, you know, there's always a kind of, people don't like discussing women's things, you know, hormones, and even women themselves can feel embarrassed. But you know, I think it's something that really we have to, in terms of even women's diagnosis. Women tend to, you know, take longer to be diagnosed with Parkinson's, and often, you know, it's because it's been mixed up with, you know, anxiety, depression, or it's just your, you know, your hormones kind of thing. So we definitely have a lot of myths to kind of dispel and get men as well as women comfortable talking about hormones. So I suppose in terms of, you know, kind of moving on, like Louise, you probably, you know, see a lot of women in your clinics with these kind of issues. You know, how are they dealt with at the moment, or is, you know, how do you see your neurology team or women dealing with it?
I work with both neurologists and care of the elderly physicians, and they're males. So the questions aren't broached by them at all. It actually, I spoke to one consultant this morning, he said, no, it doesn't even cross his mind, because he's generally a geriatrician, and I tend to see the younger patients referred from neurologists. But if you think of the percentage of patients, the majority of our ladies are older when they're diagnosed and maybe postmenopausal. And our younger ladies, I would say if a third of my patients are ladies, it's probably less than 5% are still experiencing menstrual problems or perimenopausal or having their menopause. It's interesting. I've started in the last few years talking more about their menstrual cycle, purely because of a young lady that broached it with me. So now I bring it up, and it's part of my assessment tool. So when I see a new patient, I ask them about if they're still having periods, are they menopausal? And if they're older ladies, ask them what their symptoms were like during the menopause, and have they gone since they've been diagnosed with Parkinson's, or are their symptoms the same as when they're in the menopause? And interestingly, I've had ladies even as old as 80, maybe been put on a new medication, and I've said, do you know, it's made me feel as if I'm back when I was younger and having hormonal symptoms. So I put a lady on a COMT inhibitor a few years ago, and she felt she had breast tenderness, and she was in her 80s and felt as if she was back during her menopausal state. So it's an interesting time for patients, because I think we need to raise awareness. So it's become part of my assessment tool. And what I do, I ask the girls to keep a diary of 3 months. So we've got some idea of what their pattern of their cycles are like, and how we can manage their symptoms during that week every month. I try not to alter their tablets too much, because I try to give them more long-acting medication to give them a more even delivery of their drugs. But we use dispersible Madapar as a rescue. So when they're struggling to get up in the morning to get to work, managing all your personal activities of daily living during your period, which can be difficult as well. I asked them to take dispersible Madapar to see if this will help as a rescue to minimise manual dexterity and all the problems that can arise then. I also asked them whether they are on the birth control pill, and does that even out their control and even out their symptoms as well. And it's hit and miss, because there's not a huge amount of young ladies, but some are on it and some aren't. So I haven't had a clear answer from them yet. But you know, the biggest thing that some of them say to me is the hopelessness of it. They feel helpless during this time because their symptoms are so much worse. So if we could improve their symptoms, and we even have a pathway that is sent out to all areas that deal with younger women, that they've got, even if they don't want to bring it up as a patient, but the neurologist has a pathway to follow and some tips to what type of questions to ask the patient. But I keep in close contact with the patient, and I think I have more questions and more telephone calls during that week when they're having their period than any other time of their non-booked consultations.
Well, I think, you know, it's very interesting in terms of you saying, you know, keeping the diary for 3 months, because I don't know about anybody else, but, you know, before I had Parkinson's, every month I'd, you know, might feel a bit irritable or a bit off. And then I go, oh, of course, now I know what it is. It's my period. And yet we get it every month. And interesting enough, I've been used an app, and actually I'm going through the perimenopause now, but I was kind of feeling off, and this app popped up and said, you should be having your period now. And I thought, oh, that's interesting, you know, so maybe, you know, I am, and my hormones are fluctuating. And I think the survey showed that, you know, with perimenopause, that the hormones do fluctuate. So, you know, in terms of the older women, in terms of the menopause side of things, have you any view there in terms of, you know, any of them been on HRT where it's improved, you know, their PD symptoms, or any view on that?
Yeah, I had one lady that has been on HRT, and she's in her 70s and still on very low grade patch because her symptoms were so awful pre-Parkinson's. So when she was going through the menopause, her symptoms were really, really awful. But during her diagnosis of Parkinson's, it's never been removed. And I think her non-motor symptoms have probably been less. She does have some anxiety, but it's more of an even anxiety. There are no peaks and troughs, except for when the drugs are wearing off, rather than any sort of flushes or menopausal symptoms. I think it has managed her symptoms more effectively. But a lot of my patients, even if they've got autonomic dysfunction and they're sweating anyway, they're never sure whether it is part of Parkinson's or part of menopause.
Yeah.
And we try to keep a diary of what's going on, and if there is any, it's looking at a cycle, isn't it? And whether you're premenopausal, whether you're having your periods, or postmenopausal. And I'm at that stage myself, so I understand the fluctuations. So I think I've started to develop more empathy with the older ladies that have menopausal symptoms. And I know how severe they can be, and all that brain fog, and how we don't function properly. But they all say it's the sweating is really quite profuse, but there's no pattern to it. It's not necessarily in the day, it's not necessarily at the night. It still comes over them in the middle of all sorts of discussions they're having with people. But I suppose that we need to have a comparison of what HRT makes to the difference to women who haven't got Parkinson's and those who have got Parkinson's? And then should that be part of the pathway for people with women with Parkinson's, that HRT used earlier, to try and even out control?
Okay.
Richelle,
yes.
Richelle, if I may,
Yeah.
I think we have to understand why it happens, right? So the idea behind is the estrogen seem to trigger a release of dopamine, right? So this is when you have your periods, there is a fall on the level of estrogen. So that means that some women, not everybody, because it depends on the degeneration of the system, they might feel that there is less effective dopaminergic release. This is the reason why you have the symptoms. So this is the reason why in some patients, in some people who feel that this is unbearable, because women, we are used to tolerate everything. This is the reason why we don't say that. We don't think, oh, well, this is the reason. So it might be useful to have a supplement in the treatment. But this is, I think, is important that we realize why we feel these symptoms, because there is a drop in the dopaminergic stimulation in our brain. And this is the reason why we feel all this pain and suffering much more than the normal fluctuation that everybody has during the day as a Parkinsonian.
So just on that, do you think, because I was just reading a paper there that was saying that obviously a dopamine agonist has the ability to release our own dopamine, and that potentially it could have an impact, or estrogen has a similar impact in terms of, so I'm just wondering, would it also come down to what medications a woman is on for their Parkinson's might actually also affect how, you know, their symptoms are triggered?
Well, I don't think there is a big evidence in that. As I said, you know, everybody responds in a different way because it depends on your genes, your environment. You know very well that Parkinson's is so complex. I do believe that is a personal, how much your dopaminergic buffering is, your Parkinson's is advanced, you might feel more, because the medication usually you take every day. You know, there's no, so you take the same treatment every day. So why the day in which you have your periods there is a lack? Because again, you don't have enough dopamine coming independently from the treatment that you have, you're having. Otherwise, it should cover all the time. You understand what I mean? I don't think it depends on which treatment you are having. Okay. It depends on a sudden drop in estrogen, which is not compensated by an extra treatment.
So I suppose coming on to Anne Lien then, you know, in terms of your view then, now if the estrogen drops, what can we do to treat that? Would you have a view from a gynecologist's point of view?
Yes, well, I would say it's time for a clinical trial, which we put some women on oral contraceptive continuously, and with other women have their own hormonal natural cycle and see what it does. First, I would like all these women for 3 months to keep a calendar of their symptoms, Parkinson's symptoms, as well as women's symptoms, hormonal menstrual symptoms, like, because it seems a little bit like PMS. It's in the first week before menstruation, but it's also just because of the estrogen drop, and it's also in the first week of the menstrual cycle, also still low, and then it's increasing again. So that may be a reason why some women experience this in the first days of the cycle as well still. But I think it would be really nice to do an intervention and see whether it helps, first tracking the normal state, and then put some women on oral contraceptive continuously. I would like to know what a hormonal IUD does on the symptoms, but just try to keep the hormones at a steady state and see what happens because I hear from some women that it helps. And I would just like to see that in a clinical trial.
Absolutely. And Maria, might bring you in there because you have done a lot of research in other conditions like Alzheimer's, and there seems to be similar effects in young onset Alzheimer's, in MS, you know, in other conditions. So what's your view on the sort of treatment, or as Annie says, maybe looking at doing a clinical trial around?
Yeah, well, first of all, I also think it would be super interesting to do a specific study on a number of issues that we have touched here, both observational studies and interventions. I think we have asked a lot of questions, and I think we don't really have a lot of evidence in the literature. So as a scientist, I would say, let's go for it. And I really wanted to bring this point, Richelle. We mentioned before, I think Louise mentioned before, the statistics. So in the end, most PD patients are men. So you have a relatively smaller proportion of women. These most tend to be older ladies, so a smaller proportion of young ones. A smaller proportion yet will be still, you know, in their 30s. So it looks a little bit like, you know, we're looking at a very small population. So does it really matter, you know, being the devil's advocate? And my answer is that actually this is a case in point. Do you say that in English, or point in case? I mean, it's really a good example, and it's in line with a lot of other diseases. So if it was just for Parkinson, maybe one could think it's special about Parkinson, but actually these fluctuations following the menstrual cycle and then the menopause, perimenopause, this is a common theme that we see in a lot of brain disorders. And, you know, spanning everything from pain conditions. And I really loved the comment on the vaccine the legs, and everybody knows that there is a good week and a bad week to do that. But it is true, we all know that pain is different according to our cycle. Migraine changes completely according to cycle. Sometimes it comes with menopause, sometimes it goes away. MS symptoms are completely different. Psychosis are different, even in schizophrenia. Alzheimer's is a bit of a special case like Parkinson because it tends to come later on. But we are starting to look into these topics as well with the young onset patients. So it is a common topic that spans across different fields, from neurology to psychiatry, you know, anything that is related to the brain. And that's why our name is Women's Brain Project, because we see a common theme, you know, across different conditions. And this is also why I'm so enthusiastic about the One Neurology Project, because I think if we could understand a bit better what happens specifically in women in different conditions, we might actually, first of all, serve women patients better. And second, we might actually understand something more about the functioning of the brain and the central and the peripheral nervous system, because there are obviously interactions we are not completely understanding. So I would really like to see more research and more evidence in this field.
And Kathy, you know, in terms of your sort of experience and you know, our sort of PD colleagues out there, you know, listening to everybody here, what's your thoughts?
It's basically a confirmation of everything I perceive going on in chats and in WhatsApp groups. You know, Richelle, you know, we have a group of women who chat about these topics, and everybody says, oh God, I'm feeling particularly bad. I'm on my period, I'm about to have my period. There must be a connection. And, you know, I love what Maria said just now about collecting this data and trying to make something of it for everybody, you know, not just for Parkinson's, but you know, people ask me when they say, you know, why are you so engaged in Parkinson's advocacy? And one of the things I often say is, I feel like I've got so much data in here in my body. And if I could somehow share this data, surely to God, we can find solutions for so many issues. You know, I mean, as you say, Richelle, we all use tracker apps for lots of things, you know. It's a small cohort of young women with PD, but the advantage is we're all or most of us at least, are very digitally engaged. So we can use these apps, we can get it, we can access this data, and we're just not doing it because nobody's asking these questions. And why is nobody asking these questions? Because gender bias in medicine has been prevalent for so many years. I mean, women were banned from taking part in clinical trials in the US until 1993. They're banned, not allowed, which means any drug, to the best of my knowledge anyway, any drug that was trialed before 1993 was not tested on women. You know, to me, that's mind-boggling, and we're catching up, but we're doing it way too slowly. And that's why I feel it's so important to get this data out there that's locked up inside us, and to shout out to the world that we need this data to help everybody, men and women, to understand our bodies better.
Thanks, Kathy. And actually, you bring up an important point, because the NIH brought out there a couple of years ago basic guidelines to say that any research done out of the NIH had to be, have women as well as men. And, I don't think that's sort of replicated across the world. And, it'd be amazing if it did. I think it would give us a lot more answers if just every piece of research took into account that there are, 50% of the world is women. So in terms of just a couple of the questions, in terms of actually we talk about the estrogen dropping and that effect, but do we know what's going on? Because the research does seem to indicate that estrogen has a neuroprotective effect. There is some research to show that when women have early menopause, that maybe they're increased the risk of Alzheimer's and potentially Parkinson's. And that risk might be decreased by getting estrogen therapy before 51. And the research seems to show that maybe it's an anti-inflammatory effect of estrogen, or it actually has an effect on BDNF. Has anyone here got any view on what it is about estrogen and its potential, not just for us as women to slow progression maybe, or to be a therapeutic thing to halt it, or have we any thoughts on the actions and what research we need to do to find out more about that? If anyone has a view on that.
If I may start, Richelle, I think it's very complex, right? Because estrogen, like testosterone, if we can see from the other hand, they have a complex action, and usually they act in a complex environment, right? So this is very important to understand. I think what you said, that in the past they saw that surgical menopause or oophorectomy was increasing the risk of having Parkinson's disease, right, later. And this is the reason why they started the estrogen treatment, to see if it was a neuroprotective. I think the meta-analysis now, they say that unfortunately there is not strong enough evidence to say that hormone replacement started early can protect. And this is what is important to understand, because it tells you that it's much more complex than what we think. And indeed, there is some research that say that men, they have an increased risk because the Y gene is a risk factor to get Parkinson's disease. So you see, you can see estrogen can help, but it's not only is the X to add a double X that can help you. This is the reason why I think, as Annelien was saying, we need to start a serious research in the field, and we will have an answer, which is probably very complex in the future, to better understand how we can improve, and if there's a neuroprotection effect, how we can apply to the right person.
Okay, thank you, Lena. And I suppose just on that, in terms of research, and Lynn, would you mind sharing, we had a bit of a conversation before, the research that you're doing, which I think would be quite interesting to some of the women in the audience with regard to pregnancy, I think, and Parkinson's.
Yes, thank you. Yes, for being a gynecologist and having Parkinson's disease, and after I discussed my cyclic complaints with my MD specialists in the Dutch Expertise Center, and they hadn't heard from it before, like 1.5 years ago, I thought I really have to get this out there, and it opened my eyes, and this started my mission on doing research on this topic. And because we really need to improve the quality of life of women living with PD. I've started with a literature search together with Priscilla Monica. She's from a professor in Troy, New York, and she also lives with PD. She was diagnosed, I think, last year. And we will write a review on all that's known from up to now first. And that's one of the things I'm doing. Also, I'm setting up a Parkinson, an international registry for Parkinson and pregnancy. because I think if we don't collect these data worldwide, we will not have enough data on this topic. So I want to get as much information as possible, so eventually we can inform women better if they want to become pregnant with Parkinson's. I think that's also a topic that's not discussed in the outpatient clinics. And even though, I mean, I have 3 young kids, my neurologist didn't ever ask me if I wanted more children, but maybe she thinks 3 is enough, and maybe I don't. And she didn't even ask. So I think also because she doesn't know how to deal with that or what to say. But I think it should be discussed with every woman that has a reproductive age anyways. But as long as we don't have the knowledge, it's not easy to give it, have a good management plan or give advice. So we need to collect as much data as possible. So I hope to get it out there by the end of this year. Also working on a Dutch survey on women and PD, but it's going to be a little bit more extensive than yours, but I'm really happy to see these results. So it gives me more clues for extra questions. And also a survey among neurologists in the Netherlands, because I just want to know what they're doing with this topic, if they're aware, if they discuss it, because now you've asked the women, but I want the neurologists to tell them about this and eventually also teach them on this topic, but also just get this out there. And eventually the goal is to write the guideline for management of women-related issues and Parkinson's disease with a sub top part on pregnancy. So and just all hormonal influences and menopause. And then my dream is to get some clinical trials running, but that's the next step. It's like really blank field. There's so much to do. I can get I have so many ideas, and I'm just going to do as much as possible.
So that's amazing work that you're doing, and I think it probably, one of the outcomes is maybe we need to put a sort of task force across the world, looking at research and how we could bring that together. And Elena, I don't know whether we could somehow tap into the EAN in terms of making that happen, or collaboration.
Yeah, absolutely. Just want to answer to Anne-Hélène. There was the Michael J. Fox Foundation, which was just asking for some ideas and research proposal for sex differences in
diversity call.
Exactly. So
yes, I'm going to write to that.
Exactly. So I think it can be a nice proposal. I don't know if it's already closed.
No, it's still a week to go.
Still open.
So
working
maybe,
on it.
Exactly, maybe that can be one. And the other, just because you mentioned the European Academy of Neurology, the idea of this task force is just to put the finger in this diversity between men and women in several neurological disorders, and also diversity speaking in general, racial and other identities, because as I said before, and also Kathy said, we have been used to just the main vision of diseases. And now we realize that stroke in women are different, diabetes in women is different, that cardiological symptoms are different in women compared to men, and cancer also. So, and why not neurologists should be more aware that there are differences, and we have to improve the diagnosis, the management of the symptoms. And this is the reason why the European Academy has set up this force to teach, to foster research, ideas, networks, and we put also EFNA, the patients representative in this task force to work together to this project that, as we said, is fundamental, because to hear that the neurology, they don't ask anything about that is a sort of shame for me. So we need to fix it.
Brilliant. Maria, you want to come in there?
If I can come in just exactly on this last point of Elena, and because actually Anne-Hélène mentioned a magic word, which is guidelines. I think we do have some evidence of these differences in symptoms, for instance. We have evidence of differences between men and women in the response to treatment. especially with dopaminergic drugs. I'm not sure how much doctors are aware of all this, and that's one part of the story. At the same time, because, you know, I was thinking why neurologists are not asking and why there is not enough awareness. And I've been, actually, one potential answer is that there are no official guidelines, as far as I know. So if there was this type of engagement of policymakers, of the entire medical community, but to the point that you have some guidelines, then you are saying we have a problem and we need to address it, you know. And at that point, I think specialists would be more aware and more interested in it, also because they would know what to do, because maybe, you know, you can ask for the current situation, do you have your period and all that, but then if they don't know what to do with it, they might feel a little bit lost. I don't know, Elena, what do you think about this, if that might be
yeah, the problem, we are writing the new guidelines for treating Parkinson disease with the Movement Disorder Society and the European Academy. The problem that the guidelines, they have to be based on randomized clinical trial. Exactly. So we are turning around. So there are no randomized clinical trial about this point. So you might say recommendation, which is not the same of the guidelines. So this is the reason why we need to do research, as Annelien was saying, randomized clinical trials.
Yeah.
Yes, but maybe we should just start with an expert opinion and then start clinical trials and then just get the evidence, because it need to say something.
Started somewhere.
Yeah, I think you're absolutely right. I think we need to start with expert opinion, and I mean, there's lots of areas out there where they don't have, you know, the robust evidence, but you know, in terms of you know, what's out there, I think is already a lot to be able to put forward. You need to be asking these questions. Sorry, Louise, were you going to come in there?
I was going to say, once we've got a little bit of evidence or some more from your survey, should you then try and get a place in MDS to raise awareness on the World Parkinson stage? It's still dominated by men, isn't it? But if you could get a session there, that would raise the awareness of women's issues in Parkinson's at a much bigger level, and the amount of researchers and scientists that go there as well. It may take an interest in somebody as well as everybody else, do you know?
Yeah, I agree with you, and it's something I've actually brought up with the authors of Ending PD. I was like, where's the female neurologist in there? So Basplum did say, you know, or Michael, I think, you know, the next iteration will have some women in there, but I think that's a very important point. So look, I see there's lots of questions. I'm going to try and whip through them. So Shilpa Rao, who's from Ignacio Mata's lab in South America, or it's in the States, but he does a lot of work in South America, and he's on the PD Avengers Wellness Committee, which sort of drove this survey. She said, we're facing a dilemma with launching a women's health survey. How do you account for recall bias when we discuss menses, perimenopause affecting PD? Does anyone on the panel have a view on that?
Well, I've been thinking about that, but I think it's not that big, because women just notice that it has cyclical pattern of their hormones influences. But I think by tracking for a couple of months on a daily basis your symptoms, without implying what day or what date you should have more or less symptoms, you could we can do the conclusion and say when it's worse or less. I think just with a one question on one moment, it's not that big of an evidence, but when you just track over time, we can really get some more power on this.
Can I come in on this? Because we are working with companies that are developing digital biomarkers. And one of them, for instance, is an iPad-based app, and it's actually capable of measuring very fine changes in your motor function, especially microtremors and stuff like that. So what do you think of using this type of digital biomarkers for actually having a measurement of some symptoms, especially if the motor symptoms are more affected in this period? Do you think that could be a future direction?
But in terms of clinical trials, now is not still accepted. So what we usually do is the Hauser diaries. So in all the clinical trials, there's still the Hauser diaries. The biomarkers, like digital biomarkers, there is a huge discussion, but because they can not always are reliable, it depends on which one you use. You can use it, but there is in the community, there is no agreement that they are as good in serious trial to use like the diaries that we ask the patient to do. But I won't be so surprised because for headache, for migraine, we accept that migraine gets worse or starts, or there is a big crisis in during the periods. So I don't think it should be a big bias, because then there is a bias in everywhere, in Parkinson's disease, when if you are, you have other problems like depression or anxiety, it gets worse, the Parkinson, we know that. So I don't see as a major bias.
Okay.
Can I say something,
Yeah.
Steph? I'm wearing this watch from the Personalized Parkinson's Project in the Netherlands, in Nijmegen. I'm wearing it for 2 years, and it also measures all kind of things, including my tremor. And it's easy. I'm tracking my cycle for 2 years, also these 2 years, but they're not asking for this for this. But if I could give them all the data, and all the young women in this project could, if they would track their cycle as well, you just have the evidence, at least on the motor symptoms, just because I'm wearing this watch, and there's a lot of data coming out of it. So they could have the evidence. I could share these ideas with Nijmegen if they could ask the ladies for their menstrual cycle pattern as well.
That's great. And if I can just add there, Rochelle, I'm really surprised, Elena, and interested to hear that digital measurement systems are not considered as good, so to speak, as a diary, because for me a diary is highly subjective. You fill it in once a day, and how am I feeling at that moment? I might have just had a run in with my son, or my daughter hasn't done her homework or whatever, and my tremor increases. Whereas I've also used digital measuring platforms, and you hold out your hand to the camera, and you can't fake it. You can be like this or like this. The camera catches it, So I'd love to see this catch on much more in future.
I know, but they're very rigid people in this. We have to wait. You have to wait a little.
This is
years.
one
or we
of the
have
things
to shout.
that we are advocating, because I really think this is the future of medicine at large, and in particular for brain disorders. So as Women's Brain Project, we're really pushing a lot and collaborating with some of these digital.
I think it's probably in a way, because technology moves so fast, medicine is kind of slow to catch up, and maybe that needs to change. Just coming on to another question, and Leanne, I might put this to you in terms of being a gynecologist. Yes, remember, HRT is not good for women who are blessed with Parkinson's and breast cancer. I think there's a lot of myths around HRT in relation to heart disease risk, breast cancer. Would you have any answer to that?
Unless you, of course, have a genetic predisposition, the risks of HRT on breast cancer are really that minimal that if it helps for your complaints, I would never advise not to take it. So that's more a myth than the truth. It maybe increase in a couple of women up on the thousands, and not that big of increase of a risk. So I would always advise to take.
But what is the situation of with ladies that have breast cancer? I'm a breast cancer survivor myself, just to give you an example. And
it depends. Of course, it depends on whether it's a hormonal tumor that responds to hormones or not. Whether you could take HRT, that's of course.
I think the question. Yeah.
Yes, if that's the problem, I think then you can't take it. But I think first we need to get the evidence that it helps on Parkinson's symptoms anyways first, and then if it's really that much of a benefit, you should always weigh the benefits and the disadvantages. But I think when you have a hormonal receptive tumor, or when I wouldn't take it. But
Annelienne, I think that there are other treatments. right? So we are talking about estrogen. Why I was
Also
having a
natural
nice
product.
discussion with Indu about other, other system like yoga, yeah, like hypnosis. I think we can use other treatment to cope with these fluctuations, right? Because we can't pop in medication all the time because of I think that we have to learn how to manage this dopamine lack with other technique that can be much more effective also in managing in general Parkinson disease, because we are giving all this symptomatic medication that change your brain. I always say that dopamine agonists are like cocaine. So we change, the receptors. So why we should learn a little more how to treat these symptoms in another way.
I totally agree on that, because it's just being aware of it, maybe just dealing with it better if it's discussed, or you can share with others. You can change your lifestyle, of course. You can, the days that you suffer the most, you can just do other things. Of course, there are other ways to cope with this than only putting medication in.
Just on that question, someone did actually say, should I adjust my medication during the time of my period?
I think some people do that. I think I've heard comments in this direction from PD patients. Is it possible? I guess it's not recommendable.
I think my personal opinion on it is, rather than go with what you were all just saying and give myself a break on those days for a start and just not expect as much from myself, and also just try to exercise, do yoga, etc., rather than fluctuate with the medication. Having said that, I don't know if it would help and if it's advisable. I'd be open to changing my medication on certain days. Again, it's all just a big black hole that we need information poured into.
Well, I know, for example, on the Cure Parkinson's Trust recent webinar in YOPD, one of the neurologists there actually said that he did adjust levodopa, and it does work for some. So again, we need some kind of consistency around this message. Louise, were you going to say something there?
Yeah, I was just saying, I agree with all the alternative ways of thinking about things, and using apps and using yoga and meditation and calm up and mood zone. But also, when it's so overwhelming, I do use medication, but I only use levodopa. So I leave the dopamine agonist as it stands, and we tend to use lower levels of those. We adjust levodopa doses when patients are struggling to manage during that week of their periods.
Okay. Just in terms of,
should we change the Parkinson medication, or should we adjust the hormones? Should we keep the hormones on a stable level? That's
the question,
isn't it? That's the balance. Because everything is the balance, isn't it, of what works best for the individual.
And just in terms of, I'm looking through, there's a lot of questions here, so I think we're going to have a follow-up webinar, ladies, and several of them. So I just have one here. As a postmenopausal woman, early 70s, I'm experiencing much of what is in the survey. Is there residual estrogen postmenopausal? I don't know if anyone's got any thoughts on that.
I suppose, playing devil's advocate here, a lot of the symptoms are Parkinson's symptoms as well, aren't they? And they fluctuate. So it's trying to work out, is it hormonal, or is it the fluctuations in your Parkinson's symptoms? And I suppose, again, it's a diary, isn't it? And that's the only way we're going to work out what the problems are for that individual.
Yeah.
I can give you a suggestion for that. If you have, for example, the sweatings at some time, a special time in the day, you can have just a test with Madopar or levodopa. Take the levodopa 30 minutes, 1 hour before the supposed symptoms starts. If it disappears, is a Parkinson related. If it doesn't disappear, is related to hormones.
Okay, and just one question as well with regard to dyskinesias. Women tend to suffer from dyskinesias more. So you know, I suppose if you are having worse symptoms and then you whack up your levodopa, is that going to make the dyskinesias even worse? Or, you know, what's going on there? Why are women more dyskinetic than men?
If I can take, there are several reasons. One reason is the body mass of women is less. We are used to give the same dose that we give to men. So they might have this increase of dyskinesia, and also for genetic and other complex pharmacological problems. So usually you should have less dyskinesia because there is a lack of dopamine. It's the dopamine which gives you dyskinesia. So it should be the contrary when you are stuck. But generally speaking, yes, neurologists should give women less levodopa compared to men, and probably give more dopamine agonist compared to men to prevent dyskinesia.
Okay. So ladies, I've been given the warning there that we've come to the end. I mean, it's been an amazing conversation. There's so many answers or questions that weren't answered, and I apologize. But hopefully we answered a lot throughout the discussion. I really appreciate you. So I think coming out of this, we're saying that we need to educate the neurologists. We need to do some research around neurologist understanding. We need guidelines, or maybe guidelines based on expert opinion. We need maybe a task force across the world in terms of women working in this area and men working in this area. Is there anything else that we think that needs to come out of this discussion? Or have I summarized it? Yeah. So I just really want to say thank you very much for taking part. We will be continuing the conversation. We're going to have another webinar with our other partners, PMD Alliance, later on in the month. And I think what we'll do is maybe summarize out of both panels what maybe action items we should take forward to really champion this cause and really see some change for women with Parkinson's, and hopefully maybe have some benefit for the wider PD community. So thanks very much for your time, and I look forward to engaging with you again on another webinar.
Thank you. Thank you, everybody. Bye.
Thank you.
Thank you, everybody.
Bye.
Thank you.
Bye-bye.
Bye-bye.
Bye.